Good afternoon. I'm Nirja Shah with the Illinois Chapter, American Academy of Pediatrics, and I thank you for joining us today for our webinar on HPV. This webinar is sponsored by the Illinois Department of Public Health. Today, we are joined by Dr. Gregory Zimmett from Indiana University. Participant phone lines are muted. This webinar is being recorded. If you have any questions for our speaker during the presentation, please enter them into the question box on your control panel for the webinar on the right-hand side of your screen, and Dr. Zimmett will answer them at the end of the presentation. First, I would like to introduce Dr. Zimmett. Dr. Zimmett is a professor of pediatrics and clinical psychology at Indiana University School of Medicine. He is co-director of the Indiana University Center for HPV Research and the principal investigator of Cervical Cancer Free Indiana. Much of his research has focused on attitudes about and acceptance of HPV vaccine among healthcare providers, parents, and youth in Indiana across the U.S. and internationally. He has published over 50 research and review articles about HPV vaccination. Please join me in welcoming Dr. Zimmett.
Thank you. And we'll get started here in a second. Can everyone how do I minimize the
Oh, you won't need to.
Oh, okay. So everyone can see the slides now.
Yep.
Okay. Well, I'll go ahead and get started with the disclosure slide. I'm an investigator on investigator-initiated research projects funded by Merck, and I have served on an advisory panel for Merck. I've also served as an investigator on NIH-funded research related to HPV vaccination. This webinar doesn't commercial conflict, bias, or commercial support. So I'm going to try to cover quite a few topics. I want to do a quick update on HPV vaccination rates and trends, and then talk a bit about the reasons that we know about for non-vaccination, and what we know about these reasons. And then I'm going to talk about different communication approaches that healthcare providers can use, and I'm going to start with really a simple approach to HPV vaccine communication, and then more in-depth discussion of communicating with HPV vaccine hesitant parents. And given time, I want to do a very quick update on the 9-valent HPV vaccine that was recently licensed by the FDA and very recently received recommendations from the ACIP. So let me give you some information about HPV vaccination in Illinois, which you may or may not be familiar with. These are all data from the NIS Teen Survey, the 2013 data, which were published this past late in the summer of 2014. So on this graph, you can see the U.S. national rates for 13 to 17-year-old girls, and as well as the rates in Illinois, Chicago, and Rhode Island. The blue bars are the first dose uptake, and the brown bars represent 3-dose completion. So you can see that Illinois falls a little bit below the national average in terms of first dose and initiation as well as 3-dose completion. Chicago does better than the state as a whole, though, and is over the U.S. average. The state that all of us, Indiana, Illinois, and the rest of the country, really should be working to emulate is Rhode Island, which really has done an extraordinary job with HPV vaccination. You can see that they're the leaders in the country. This is HPV vaccination of males. The Illinois rates actually reflect pretty closely the national rates of both first dose uptake and 3-dose completion. They're, as you can note, much lower than female vaccination rates, which is, of course, at least in part or largely due to the fact that it was licensed and then much later in 2011 than 2006, and then the routine recommendation didn't come out until 2011. Chicago, again, is doing a really good job. Ireland really leads again in terms of male vaccination. This gives you a look at the trends in HPV vaccination rates over time for 13 to 17-year-old girls and boys in Illinois. And you can see there was a little bit of a dip in 2012, but things are on the upswing again, and hopefully with the amount of attention that's being paid to the need to increase HPV vaccination rates, I'm very hopeful that the upwards trend will continue in 2014 and throughout 2015. For a variety of reasons, I suspect that we'll see a narrowing of the gap between boys and girls as well. So as part of trying to develop interventions and ways of communicating to increase vaccination rates, it's important to understand reasons for non-vaccination for HPV. And part of what's important to realize is that the concerns about vaccination have been with us as long as vaccines have been with us. And I show you here, this is a cartoon from 1807 by an anti-smallpox vaccine person depicting Edward Jenner on the left, who's dumping children into this monstrous cow, and the cow then excretes them. And you can see Ed Jenner is depicted as like a cow with horns coming out of his head. And the cow has these open sores or pox on it. And it was believed at the time by some people that smallpox vaccination could lead to pestilence, could open Pandora's box, could lead to leprosy, to plague, and to dreaded fetid ulcers. So it's important to recognize that there's not been a time in the history of vaccines that there hasn't been some anti-vaccine sentiment. I think it waxes and wanes for a variety of reasons, but it's something that has always been with us and probably will always be with us, although it's really important that we make efforts to decrease this kind of sentiment. So looking at reasons for non-vaccination, this was a study that my colleagues and I did. In 2010, we surveyed about 500 mothers of 14 to 17-year-old girls. This was a U.S. national sample, and about 50% reported non-vaccination of their daughter, which pretty much reflected the national data from that time period. And these non-vaccinating parents were asked to indicate reasons for non-vaccination. So you can see on this page that, and parents were allowed to choose more than one reason. So you can see frequently endorsed by over 35% were side effect concerns and safety concerns, which I sort of see as related concerns. But these two concerns were followed very closely by parents saying that their daughter's doctor had not recommended HPV vaccine. So these are the major ones. Then falling way behind is that there's no recent doctor's visit. An issue that's gotten a lot of attention, but in fact really has very little to do with parents' non-vaccination, is fears about sexual disinhibition. That somehow HPV vaccine will lead to initiation of sexual activity at a younger age or less protection. We more recently did a survey of nearly 780 parents of 11 to 17-year-old boys. This was in 2012. And again, this was a U.S. national sample. 71% of the sample reported non-vaccination of the son. And these parents were asked to indicate reasons for non-vaccination, much like the parents of the daughters. And in this case, it's really a somewhat different pattern of results. In this case, over 60% of the parents said that they had not received a doctor's recommendation for their son to be vaccinated. A little over 30% said they didn't know it was for males. And this actually continues to be a problem. A fairly large percentage of parents still don't know that HPV vaccine has been recommended as a routine vaccine for 11 to 12-year-old males. And falling at a much lower level are issues like side effects and vaccine safety, which you remember for girls was a much more prominent concern. And again, disinhibition issues really barely registers. Other reasons for non-vaccination that can be found in the literature is parents saying that their child is too young and in a related risk, that the vaccine is too new, and there are questions also whether the vaccine really works and whether it lasts long enough. So what do we know regarding these reasons for non-vaccination? And so it's really important to be aware of the research that can address these reasons. It's not necessarily helpful to talk to parents in extreme detail about these things, but it's really important to be knowledgeable about them. So I'm going to go through these issues: vaccines are too new, safety concerns, my child is too young or not at risk, doubts about vaccine effectiveness, the issue of sexual disinhibition, and the lack of recommendation. So are HPV vaccines too new? The quadrivalent vaccine has been licensed and recommended for girls and young women for nearly 9 years, and that was after many, many years of research and testing. And it's important to remember that the MCV vaccine was licensed just 1 year before HPV-4. So it's not as if that's been around that much longer. The bivalent vaccine has been licensed and recommended for girls and women for over 5 years after many years of research and testing. And the quadrivalent vaccine has been licensed for boys and young men for over 5 years. And beyond that, many, many, many millions of doses have been administered in the U.S. and worldwide. So are vaccines, HPV vaccines, too new? I think the answer is very clearly no at this point. They're not too new. They've been around for years and have been well tested. Is HPV vaccination unsafe? And I'm just going to say right up front, no, it's not unsafe. It's the concerns that parents see very frequently on the web are based on individual stories which may be very tragic but actually do not implicate HPV vaccine. One or even several stories by themselves cannot address vaccine safety. And I think important questions that need to be asked when parents see stories on the internet is when there's a proposed connection, what is the mechanism of action? And if there isn't a reasonable mechanism of action, it's a good reason to doubt that there's a causal connection. And I think the other thing that's really important is to examine what the research shows when large numbers of people are carefully studied, because the only way we can begin to get a sense of any kind of causal association is with large epidemiological studies. There's been a lot of media distortion and miscommunication, particularly of the vaccine adverse events reporting system data, where many people assume that if an adverse event is reported, it must be caused by the vaccine. And unfortunately, I think people still don't understand how the VAERS system works. And this is an example. This is from quite a few years ago in a Canadian magazine, Maclean's. But in this article, it claimed that the VAERS system showed that that HPV vaccine had led to a whole series of serious problems, when in fact a careful analysis of the VAERS database indicates no problems with HPV vaccine. So what does the research actually show? Safety continues to be closely monitored by several different systems. Again, as I mentioned, the VAERS data to date show no significant concerns about safety. And a study based on over 600,000 doses of vaccine found no increased risk for strokes, seizures, allergic reactions, or many other conditions. Some recent studies, so this is a very recent study published in 2013. A study in Denmark and Sweden examined autoimmune, neurological, and other adverse events. It included nearly 1 million girls, of whom about 300,000 received HPV vaccine. This was a quadrivalent vaccine, which means about almost 800,000 received no vaccine. When those two very large groups were compared to each other, they found no increased severe adverse events of any kind in the vaccinated versus unvaccinated group. Another study, and this is really just hot off the press, published in JAMA this year, also in Denmark and Sweden, included nearly 4 million young women Nearly 800,000 had received HPV vaccine. The remainder were unvaccinated. And in this case, they were looking specifically at multiple sclerosis and other demyelinating diseases, and they found absolutely no increase in the vaccinated versus unvaccinated group. There's probably, I mean, the amount of data now on the safety of HPV vaccines is pretty overwhelming, showing that they are, you know, by and large, very, very, very safe vaccines. So is HPV vaccination unsafe? No, it's quite safe. It's probably the safest vaccine we have. As with any vaccine, there are risks of common vaccine side effects, tenderness and swelling at the injection site, mild fever, fainting in some cases. Certainly no vaccine is 100% safe. And I think it's important in talking to parents to acknowledge that there are these kinds of mild side effects. And there can be cases of anaphylactic shock, certainly, and that would be true for any injection. But it's also important to communicate. Nothing we do or have our children do is 100% safe. And but one thing you can say with tremendous confidence that it's safer to get vaccinated than to not get vaccinated. The concern of a child being too young or not at risk. So the point, obviously, of a preventive vaccine like HPV vaccine is to vaccinate before exposure. And I think, you know, there is a degree of a lack of vaccine literacy among the public and sort of a confusion about what a preventive vaccine means. So I think it's helpful to remind people that a preventive vaccine is a vaccine you want to administer before someone is exposed. The other argument for younger vaccination is that vaccine-induced anti-HPV response is significantly stronger among younger versus older teens. Also, most persons will eventually be infected with HPV, so in a sense, nearly everyone is at some risk for infection, and a subset of those individuals are at risk for disease. We also know that vaccine protection lasts at least 10 years, but probably much longer. And it's important to make it clear that it's at least 10 years. Parents sometimes tend to hear 10 years and say, well, only is going to last 10 years. Well, at this point, we don't know how long HPV vaccines will last, but we do know that they provide fairly long-term protection and that they probably can be boosted quite effectively. So child too young, not at risk? No, there's no reason to delay vaccination. There's good reason to vaccinate at the targeted ages of 11 and 12. There's some who claim that HPV vaccination is ineffective. If that was true, the vaccine would never have been licensed by the FDA to begin with. The clinical trials really indicate pretty convincingly that both the quadrivalent and bivalent vaccines are quite effective. HPV, the bivalent vaccine, is approved and licensed and shown effective at prevention of cervical cancer and precancers, and the quadrivalent vaccine at prevention of cervical, vulvar, vaginal, and anal precancers and cancers. And the quadrivalent vaccine, obviously, is also effective at prevention of genital warts. Studies in Australia and Denmark in particular. Now, these Australia and Denmark have extraordinarily high HPV vaccination rates, so there's been a lot of effectiveness studies that they've been able to carry out. And studies clearly show marked decreases in cases of genital warts after vaccination was initiated. And they've even found this among non-vaccinated males, which is an indication of herd protection through vaccinating females. And they've also found, beyond the decrease in genital warts, they found decreases in cervical abnormalities. So the research is pretty overwhelming that HPV vaccine is effective. And even in the United States, with our relatively lower vaccination rates, a study in 2013 demonstrated pretty convincingly that vaccine-type HPV prevalence had decreased among 14 to 19-year-old girls. Again, as I mentioned before, there's no evidence of waning effectiveness over 8 to 10 years after vaccination, and there's very good evidence that the vaccines can be boosted if needed. So HPV vaccine has clearly been shown to be very effective. So even though this is not a big concern of parents, it's the kind of issue that shows up in the media a lot because it makes for a good story, I think. the question of whether vaccinating girls or boys against HPV somehow could lead to sexual disinhibition. This cartoon, I think, illustrates sort of the absurdity of that idea, but there's also research that addresses this. So there have been over 15 studies, I believe now 17 studies published since 2012. Not a single one of these studies show evidence of sexual disinhibition following vaccination. 3 of these 15 studies actually, in addition to looking at self-reported sexual behavior, also looked at biological markers and outcomes. So they looked at sexually transmitted infections. One of the studies looked at pregnancy. And again, not one of these studies shows any marker, any indication of sexual disinhibition. So the question, does HPV vaccination lead to sexual disinhibition? The answer is resoundingly no. There's no evidence at all that that happens. And I would go further and really say that even if it did lead to sexual disinhibition, that's not a reason to withhold vaccination. It is, in my opinion, unethical on the basis of concerns about this to withhold vaccination. If we were to find evidence of sexual disinhibition, we would need to address that issue and specifically, but not withhold vaccination. We wouldn't do that with any other vaccine. So the issue of not being recommended by providers, this clearly is a real issue and a real problem. Healthcare providers very clearly generally support HPV vaccination, but also report a lot of barriers. There are some logistical barriers, things like cost of stocking the vaccine, concerns about reimbursement. There's some healthcare providers that have had questions about safety, although as we've shown, it's really a very safe vaccine. And I think in general, there's sometimes variable levels of knowledge about HPV, about the diseases it causes, and about the vaccine. Non-recommendation has been a particular problem with male vaccination, although I think that may be changing. Also, healthcare providers talk about more comfort with vaccinating older versus younger adolescents, and this is consistent to what parents say as well. So it's almost as if parents and providers are have a kind of silent agreement to put off vaccination after the recommended ages of 11 to 12. And again, remember that that HPV vaccine is recommended as a routine vaccine for 11 and 12-year-olds. Multiple studies show that adolescents and parents who received a clear recommendation for HPV vaccine from a healthcare provider had a much, much greater odds of getting vaccinated. So this is the other side of it, that recommendation by healthcare providers is quite powerful. But the lack of recommendation is probably among the primary reasons for a relatively high non-vaccination rates. And it's something that I think we all can do something about, which is the good news. So in terms of talking with parents, my recommendation would really be to start simple, to not make this a complicated issue at all. So make it routine. Essentially, there are 3 or 4 recommended adolescent platform vaccines. There's Tdap, HPV, meningococcal vaccine, and influenza. Don't separate HPV from the others. It is a vaccine, just like Tdap is a vaccine, just like MC4 is a vaccine. My recommendation is actually to put HPV in the middle. So typically, HPV is mentioned last. So a lot of times healthcare providers will say it's time for Tdap and meningococcal vaccine. And oh yeah, we also have this other vaccine, and that leads to then this sort of complicated and awkward discussion. And I think if HPV vaccine is placed in the middle, there's going to be less of a tendency to sort of carve it out and treat it differently. So instead say it's time for Tdap, HPV vaccine, and meningococcal vaccine. I think this approach can help healthcare providers to avoid hesitating before mentioning HPV vaccine and help to encourage that kind of routine, matter-of-fact recommendation. And it's important to not just offer. Again, this is a vaccine that is recommended as a routinely administered vaccine. So assuming it's not a visit during flu vaccine season, you might say something like, I recommend 3 vaccines for this visit. Tdap to prevent pertussis, the first dose of HPV vaccine, which prevents cancers, and meningococcal vaccine to prevent meningitis. I strongly recommend all 3. What questions do you have? So that's a pretty simple script. It doesn't take very long, and it communicates that very clear, routine recommendation, but at the same time leaves open discussion for parents who have questions. Two additional points. Make sure to make the same routine recommendation for both boys and girls, and ideally, and according to all the recommendations starting at age 11 to 12, there might be some advantage to beginning HPV vaccine if a child should show up for a visit at 9 or 10, because it's licensed for 9 and 10-year-olds, and because it's a multi-dose vaccine, there might be some advantage to beginning it early if that opportunity presents itself. And then the second or third dose can then be given along with meningococcal and Tdap. Also, after administration, obviously, it's really important to emphasize the importance of returning for the second and third doses to get full protection. So sometimes a very simple direct approach. I'm thinking that most of the time that's going to be all that's required, but there are going to be times that parents are hesitant about vaccines in general, or maybe hesitant specifically about HPV vaccine. And those parents may want some more information. So I think this is where it's really important to be well informed, to be prepared to answer questions in simple and clear language about safety, about reasons for vaccination at ages 11 to 12, about effectiveness, and why boys need the cervical cancer vaccine. And this is sort of a downside of the way HPV vaccine was marketed. It's now kind of confusing. Why would boys need a cervical cancer vaccine? So I think it's important when encountering a vaccine hesitant or concerned parent to recognize that parents like you as providers really share one thing for sure in common, which is protecting that child. And even parents who don't want to vaccinate, they may be misguided, but what they want to do is protect their child. And it's important to recognize that and be careful not to undermine that. And this is a set of slides from a colleague of mine, Hal Willoughby's at the University of Sydney in Australia. And it illustrates in a somewhat funny but I think very compelling way the parental protection instinct. So here's a mother squirrel. She's on the side of a tree. And you can tell she's agitated because her tail is up over her head. And the reason she's agitated is she sees that there's a dog, a Labrador, that has her baby, I don't know if you can see, right between the dog's front paws. And she's very worried about her baby squirrel. And so this is the parental protection instinct. She jumps on the dog, who's obviously much, much bigger than her, and you can see the baby squirrel make its escape. And there she is, intensely attacking the dog and distracting the dog from her baby. And here you can see the final picture. The dog's looking completely confused, and the mother and baby are safely up the tree. I think the lesson here is that most parents are fiercely protective of their children, and what you want to make sure is that you don't end up being the dog. And there are ways to do that, to be consistent and true to your profession and your judgment, but at the same time not be the threatening dog. So expression of anti-HPV and anti-vaccine sentiments or hesitancy can sometimes provoke frustration and anger in physicians and other healthcare providers, which can lead to a rigid refusal to be manipulated. It can sometimes lead to overcompensation, a kind of giving in to patients' demands. Sometimes can lead to turfing or avoidance of the patient or the vaccine, and also awkwardness around the recommendation. We see that with HPV vaccine in particular. I'm going to just show a couple of examples of of dialogues, and one less productive and one more productive, and they're adapted from a variety of sources, including Ed Marcuse, who has done some really nice work on communication about vaccination. He's at University of Washington, Seattle. So here's an example of an unsuccessful approach. The healthcare provider says, your daughter's due for some vaccines today. There's Tdap and meningococcal vaccine. Oh, and we can also give her that HPV vaccine. The parent says, that sounds like a lot. I'm not sure I'm comfortable with that many vaccines at one time. The physician says, you have nothing to worry about. We know it's safe. And this is really the point at which the dialogue begins to go off track. And the physician's not listening to the parent's concerns and instead is just trying to kind of say, there, it's okay. So the parent says, well, I've heard that too many vaccines at once can overwhelm her immune system. I've seen research on the internet about this. Also, I've heard that HPV vaccine is too new and may not be safe. The physician, in an attempt to push back against that, says he trusts his website. Good scientific research shows that vaccines are safe. The parent says, I still feel uncomfortable about these vaccines, especially HPV. I know my daughter's not having sex. We've raised her right. And the physician says, well, but how would you feel if your daughter ended up getting cervical cancer? And now it's really gotten, they're really in opposite corners and at loggerheads. The parent says, I don't think that's the same thing. The physician, frustrated, says, your daughter just needs these vaccines today. The parent ends with a true statement, she's my daughter, I'll make that decision. And so this starts out, goes off track fairly quickly and then goes as the dialogue goes on. Here's an example of a more successful approach, and you'll see that how it doesn't go off track as early, and it doesn't mean necessarily that at the end of this discussion the parent's definitely going to vaccinate, but it keeps the parent engaged. So again, it starts out the same way. Your daughter's due for some vaccines today. She'll be getting a total of 3 shots, Tdap, HPV, and meningococcal vaccines. You'll notice I put HPV in the middle. Parent says, like she did before, that sounds like a lot. I'm not sure I'm comfortable with that many vaccines at one time. And here's where there's a first difference. So instead of saying it's safe, the healthcare provider says, well, tell me, what concerns do you have? And the parent says, well, I've heard that too many vaccines at once can overwhelm her immune system. I've seen research on the internet about this. Also, I've heard that HPV vaccine is too new and may not be safe. The healthcare provider, rather than sort of saying you can't trust the site, says, I understand that you want to do what is best for your child, so do I. This is really important because this is that common ground, finding that common ground. Many parents feel bombarded with conflicting information and do not know whom to believe. The parent says, from what I've seen on TV, I'm not sure I can trust the ingredients in vaccines. Science isn't always right. Healthcare provider says, I recognize that science doesn't provide answers to all the questions that concern you, but science is the best tool we have to get reliable answers to important questions. Let's take some time to talk about your questions about vaccine ingredients. Then, if you'd like, I can give you some trustworthy information sources about vaccines. So this doesn't push the parent away, but really tries to engage the parent in a conversation and opens up the opportunity to provide corrective and correct information. We know from research study after research study, parents want to talk to their physicians, to their healthcare providers. The healthcare provider is the most used and trusted source of information about immunization. But parents do report problems with the content of discussion and the nature of how the communication goes and how the interaction goes. And a lot of that is, I understand, the kind of pressures that primary care, healthcare providers, and physicians face, and there's not a lot of time to have in-depth discussions. But I think the majority of parents, again, I really want to emphasize this, the majority of parents do not require intensive intervention around HPV vaccination. The very simple, straightforward, routine recommendation, just as you might recommend meningococcal vaccine and Tdap, should be pursued for HPV vaccine. Now, for HPV vaccine hesitant parents, it is important to develop a kind of decision-making partnership. So for those parents, you do need to spend a little bit more time. It's important to be informed about the research and to be able to communicate the kind of information to parents and to patients. It does reflect a shift from a more paternalistic model to more of a shared model of decision-making. But ultimately, I think it's a more effective approach to dealing with vaccine-hesitant parents that helps empower parents to make informed decisions with accurate information. But again, it's really important to know and be comfortable with the facts about HPV vaccination so that those facts can be communicated in an effective way to parents. And I do have some time, so I'm going to go over the 9-valent HPV vaccine just to make sure I bring everyone up to date. You may be aware of this, but again, it was the 9-valent vaccine, which is the same as the quadrivalent, but they added 5 additional oncogenic types. So it has potential to prevent up to 90% of cervical cancers. The direct benefit is greater for girls than for boys, but boys benefit as well to an extent. So it was licensed by the FDA in December of 2014. The ACIP discussed the 9-valent vaccine in February in terms of recommendations, and they made a decision. So when the FDA licensed this for males, they only licensed it for ages 9 through 15. For females, it was 9 through 26. So the question was, what will ACIP do about old boys? And what they decided to do, which I'm glad to hear, is basically stick with the same recommendations, the same age and gender recommendations that they had for the quadrivalent vaccine. And so those recommendations, as you know, for females 9 to 26, with routine recommendation for 11 to 12 and routine catch-up for 13 to 26-year-olds. For boys, it can be given to 9 and 10-year-olds, routine recommendation for 11 to 12, routine catch-up for 13 to 21. For men who have sex with men, routine recommendation for 22 to 26, as well as for males who are immunocompromised. And for males who don't fall into that category, they're still approved for males 22 to 26 and they can get the vaccine, but it's not a routine recommendation. ACIP also recommended finishing the vaccine series with whatever vaccine is available. So it doesn't matter what you start with. You can start with the quadrivalent or the bivalent and finish with the 9-valent. So far, they're not choosing the 3-dose schedule. There's some discussion about potentially moving to a 2-dose schedule, particularly for a younger age range. The World Health Organization has recommended a 2-dose schedule, I believe, through age 15. But in this country, that's not happening yet. There's no determination yet on what recommendations be made for those who are already fully vaccinated with the bivalent or quadrivalent vaccines. So people have a lot of questions about what to do in this case. So I think one of the things that's important in terms of the focus of my talk is to anticipate the kind of questions that parents will likely have about the vaccine once they hear about it. For parents who are vaccinating, that may very well arise is a way to vaccinate. And the recommendation is that they shouldn't wait to vaccinate, that they should go ahead and vaccinate with whatever is available. And the reason for that is that it's often hard to get young people, 11 to 12-year-olds into the doctor. And so you really have to strike while the iron is hot, if you will. But this is a question parents will likely come up with. We've done some focus groups with parents, a series of focus groups with parents of unvaccinated girls, and this was a question that came up. Another question is, it's new, so do we know it's safe? To talk about the 9 vaccine, not new, but as an improved than existing vaccine. Another question, we also posed groups of parents of daughters who were fully, my daughter got her third shot of HPV, can she get revaccinated? So this is likely to be a question. And parents may also have questions about other around the corner, should they wait, because maybe in a year or two they'll be even better back. Likely, that's the kind of question I'm got his first 2 shots with the old vaccine, finished with the new vaccine. And this we have definitive answer to, which is the ASAP-yes. Other questions that parents that are likely to have and that parents talked about in the focus groups that we ran is, will insurance cover it? Again, this should not be an issue. Eventually, insurance companies, sooner or later, probably more sooner than later, should cover the non-valent vaccine, and the Vaccine for Children's program also should. But this is a question, again, parents have questions about, or an issue that parents have questions about, particularly an issue for parents whose daughters or sons have been fully vaccinated. It seems less likely that a fully vaccinated a child that's fully vaccinated with a quadrivalent or bivalent vaccine is going to have insurance coverage to get revaccinated with a bivalent vaccine. And that's all I have to present today, and I'm happy to answer questions.
Thank you, Dr. Zimmet. That was a really great presentation. If you guys have any questions on the presentation, please enter them on the right-hand side of your screen. We're in the questions box, and we will keep this line open for a few minutes for the questions. Dr. Zimmet, there is one question. Can a 27-year-old recommend the final dose if given the first one and the second one at age 26?
My understanding, and I would, since it isn't licensed, the vaccine isn't licensed by the FDA or recommended by ACIP for anyone over 26. At the same time, there's no reason it can't be administered off license. I mean, a lot of times medications are prescribed off license. So it could be given. I think the question would be whether it would be covered by insurance at age 27. I think you would want to try to finish the series. And this is related in part to the 2-dose schedule. So, if a 2-dose schedule is ever adopted, it would be at 0 and 6 months minimum. That what they've found is that you really need quite a few months in between the first and second dose. So someone who's received the first 2 doses with the traditional schedule, that would mean that they got the first dose and then the second dose typically 1 to 2 months after the first dose. And they really need that last booster dose to really kick in the best protection. So I would say, from a clinical judgment perspective, you would want to try to get the 3rd dose in. I think the question would be, 1, it's off-label, and 2, because of that, it might not be covered by insurance.
Okay. And there's another one. You mentioned shared decision-making to improve vaccination rates. Is there literature specifically for HPV related to this and or motivational interviewing as it relates to HPV?
So there is literature on other vaccines. With HPV, a lot of the literature is still kind of in process and emerging. there is, so people are doing the kinds of studies to look at motivational approach decision making, but I'm not aware of anything that's been published yet. There has been some research on, we've been conducting some research on trying to encourage a kind of routine recommendation of the 3 vaccines, and that seems to have been fairly effective. But I really see the MI and the shared decision-making approach as being a second-level approach. That's for the the more hesitant, very simple recommendation like we do with other vaccines. But I have yet to research studies come at exploring the effectiveness of kind of motivational interviewing approach with HPV vaccine hesitant families.
Okay. And then another one. How do you combat the comment or argument from parents that vaccine manufacturing companies are who they are, or who are the real encouragers for kids to get vaccinated? I've heard this from parents who refused to vaccinate in the past. I don't know.
Yeah, so I think it can be a kind of difficult opinion to comment, because certainly there's a lot of negative feelings about big pharma. I guess the approach, if you can, the way to approach this is really to ask more questions about it, and to see if there's a way to help them move towards because the fact is we live in a capitalist society where pharmaceutical companies are in the business of making money. And so it's certainly true that they're in the business of making money. But I think if what you hope to be able to do is move them to a more nuanced understanding that pharmaceutical companies may make the vaccine, but a lot of the testing, the evaluation of the vaccine, and in fact, a lot of the development is not done by the pharmaceutical company, it's done by researchers independently from the company. And the regulatory agencies are not employed by the pharmaceutical company. And in fact, we have a pretty good history of, if anything, overreacting to presumed dangers of vaccines. So I think the more that you can move people to a more nuanced understanding, rather than taking it on directly, because I think you can acknowledge, certainly, pharmaceutical companies are in the business to make money. That's how our society works. But to talk about the other factors that go into evaluating vaccine effectiveness and safety might be helpful.
Okay. Does a newer vaccine cover the HPV strains that are most often seen in cervical cancer among African Americans?
Yes. Yeah, there was some. So there was a study that, to my knowledge, has not actually been published. It was presented that got a reasonable amount of attention. This was like a year ago or 2 years ago, that suggested that the quadrivalent vaccine and bivalent vaccine, that type 16 and 18 didn't represent the most frequently occurring types associated with actual cervical cancer in African American women. I've yet to see that confirmed, or even to see that study published. But I think what is true about the 9-valent vaccine is that it covers 5 additional types. So I think regardless of, there's some variation, at least based on geography, which types are predominant. But I think with the 9-valent vaccine, we've got just a huge number covered, and there should be less, I would think, less geographic variation. Maybe in some areas it would be 85% of cervical cancers, and in other areas 92%. But particularly with a 9-valent vaccine, that shouldn't be an issue. And again, even if it was, I guess my argument would be also, even if it's as low as 60%, let's say with a quadrivalent vaccine in certain groups, it's 50 or 60%, that's still great. We have a cancer vaccine. and any degree of protection is impressive.
Okay. You state that provider recommendations is the biggest barrier. Do you have specific sources that support this for using as future research or QI projects?
Yeah, I mean, there's quite a bit of research that that identifies, so from parents' perspective, that they haven't received a strong recommendation, and that's their reason for not vaccinating. The reverse, which is parents who say they've received a strong recommendation rather, and those parents tend to, their kids tend to be vaccinated. Even research with providers where they will talk about some concerns about vaccinating 11 and 12-year-olds and wanting to put it off to older ages. So there's a lot of research on providers not being comfortable giving strong routine recommendations. All providers by any means, but in general, family medicine, pediatric providers, there's some hesitation about making a strong recommendation. And there are efforts to, I think the AAP actually has been really working on various maintenance of certification projects and QI projects. So I think there are a lot of efforts. That's why I'm actually fairly optimistic about 2014 and 2015 in terms of vaccination rates, because there's really been a concerted effort by the AAP and by the CDC to address and help, really to help teach providers how to make this a routine recommendation and implement that in practice. So I think we'll see some changes. And I hope, does that answer the question?
I would hope so. And I think this is the last question. What has Rhode Island done to make their HPV vaccine rates so much higher than the other states?
Yeah, well, that's always a great question, and my understanding. So I think it's a couple of it. So, one is they're a tiny state, which makes it easier. I mean, they have a concentrated population, unlike Illinois and Indiana, which have huge rural areas. Rhode Island does not have huge rural. They can't have huge areas of any sort. It's so small. So, part of it is just the concentration of population makes it easier to reach the population. They also have had a kind of situation where my understanding is that there's been a kind of synergy of the different agencies in Rhode Island, the Department of Education, the Department of Health, and the Catholic Church as well, which is very strong in Rhode Island, to all come out in favor, strongly supporting vaccination, all kind of vaccination in middle school and high school. So, I believe the name of the program is something like Vaccinate to Graduate. It's sort of, I may be wrong there, but it's something like that. And so there's really been just this very integrated, concerted effort that's been supported by multiple, public and religious segments of society in Rhode Island.
Great. Dr. Zimmet, I think that's all we have for questions. Just going to close this webinar out then. Thank you for joining us on today's webinar. Please join us on our next webinar on April 21st at noon, where we will have Dr. Mariolata Pierce from Pierce Pediatric Associates presenting on National Infant Immunization Week. This webinar will sponsor CME, CNE, as well our entire webinar series this year. Shortly after this webinar, you will all receive an email with a link to the recording of today's webinar, as well as a PDF of the PowerPoint slides. Rush University will be sending a link via email to complete the evaluation to all that participated in the webinar, and will be sending the certificates as well. Once again, thank you to Dr. Zimmet for presenting, and everyone else for joining us on today's webinar, and I hope that all of you have a great afternoon. Thank you.